Good afternoon and welcome to Wrapping Medical Device Utilization Data and Performance Metrics in a Risk Context to Improve Threat Detection and Response, a Health System CIO Media Inc. production, sponsored by Medigate by Clarity and First Health Advisory. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments in the Q&A box, and we'll take them later in the program. Nice way to view the screen. Click on the top center, get it in side-by-side mode. Then you can adjust the divider to get the slides in the video boxes the size you want them. And it should say speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, first we're going to have our main panel discussion featuring Matt MacVay, VP and CIO at Children's National Hospital, Carter Groome, CEO with First Health Advisory, and Tom Finn, Director, Market Development with Medigate. All right, so let's jump right in and get started. Matt, let's start with you. Can you give us an overview of your organization and your role?
Sure, Anthony. Thanks for the opportunity. So my name is Matt MacVay. I'm the Executive Vice President and Chief Information Officer here at Children's National Hospital, a role I've served in for the last 2.5 years, 20 years in total in healthcare IT, and really over the last couple of years, it's been an honor to serve Children's in the CIO capacity, but also help in concert with our Chief Information Security Officer build a security program, and looking forward to talking a bit about that today. Organizationally, we're a 330-bed hospital located in Washington, D.C., and we serve the entire D.C. metro and beyond, right, with national, international patients drawn to our centers of excellence. Top 10 pediatric hospital with a huge research investment as well, with top 10 NIH grant funding for pediatrics. So a wide variety of clinical research and other community service activity that we do here at Children's, and look forward to sharing some of our work in the security realm with you today.
Very good, Matt. Thank you. Carter?
Anthony, thanks for having me. Good to be here with some friends, Tom and Matt. First Health Advisory is a healthcare asset-centric cybersecurity and risk advisor. And we advise hundreds of commercial entities, government healthcare entities, and our managed solutions really get to the core of reducing patient safety and enterprise risk. And as a benefit to the programs that we deliver, there are what we like to call capital avoidance value elements, and by understanding how devices are utilized, we're really uncovering efficiencies in the life cycle of operational IoT and medical devices. And my role as CEO of First Health Advisory is to constantly assess that threat curve to ensure that our services and our technology partners like Medigate work to put our clients in the best posture to protect their organizations and really the healthcare ecosystem at large.
Very good, Carter. Thank you. Tom?
Yeah, thanks, Anthony. I'm Tom Finn, Director of Market Development for Medigate. I'm kind of an evangelist for the company, been with them from the get-go, going back now about 4 years. And as I have been in healthcare for most of my career now, more than 30 years, it's been an interesting ride. I've always been associated with tech transfer into the healthcare space and witness here the adoption of these IoT cybersecurity technologies run faster than I've ever seen any other example of. It's been an interesting ride, to say the least. Instead of us trying to convince folks this year as to what they need to be thinking about, they're telling us exactly what they want. And that's a rather notable change that's occurred in a very, very short period of time. Anyway, thanks so much for having me.
All right, very good, Tom. All right, Matt, we're going to start with you on this first question. Today we're going to talk about some ways health systems can improve medical device security. Let's set the stage by talking about why it's so challenging. What are your thoughts here?
So I think that it starts with the vastness of the challenge, and just to set the stage here, over the last 6 months, we've seen 50,000 devices on our network. We've used Medigate to tell us that information, but and they're of all sorts, right? So as a broad enterprise focused on research activity, clinical care delivery with great specialization, just the sheer number of different types of devices, and both for medical care delivery, but IoT devices, and then also our core IT assets. It's just the vastness of the problem. And so for us, step number one is to get visibility to those devices, which we've pursued, and be able to start to understand, are these managed devices, are they unmanaged? And then, as we'll talk about today, then starting to get more sophisticated about how do we correlate those devices, and then ultimately manage the vulnerabilities that they present to our organization. Certainly there's, the context is also clear, I think, as most are probably aware, around our ability to patch and manage some of these types of devices, particularly those that are with FDA clearance, presents another challenge. So it's not only the vast number, it's how they can or cannot be managed, but then also making sure there's clear lines of accountability and ownership for the sets of devices we're talking about here today.
So the vastness of the variety, managed and unmanaged, and the unmanaged ones, agentless, as they say, are more difficult.
Absolutely, absolutely, and I think that's the, that's the importance of being able to have something that recurringly gives us the visibility to those items on our network.
All right, very good, Tom.
Yeah, as far as just commenting further, you mentioned unmanaged devices. Just to add a little bit of context there, obviously in the IoMT realm in particular, you see a lot of undocumented, often proprietary transmission protocols that they use. That's part of the reason why they're very difficult to discover in the first place, let alone manage. In addition to that, as we know, these devices were not manufactured with security in mind. So scanning them for vulnerabilities on a remote basis is, again, generally a no-no that, in fact, will directly violate warranty provisions. So there has to be a passive method invoked in order to get your arms around the problem. And that's where a lot of the technology advances have taken place over the last several years. There's a way to do it now where information can be aggregated from managed devices that enjoy the benefit of an agent being installed on them that can provide that information, along with methodologies, passive methodologies, as I mentioned, where the information can be parsed directly from the network traffic flows. You put that all together, and notions of comprehensive visibility are realistic now. They're achievable. It's happening.
Tom, you mentioned it, and we often hear complaints that these were not manufactured with security in mind. They're very expensive and they last a long time. They're in use a long time. So you don't just throw them out and pick up new ones. But are the ones being made today, are they being made with security in mind? Is this a problem that over time will go away as devices that are built more to security are more in the market in use?
I think the short answer is no, the problem is not going to go away for all kinds of reasons, not the least of which is investing in what may be tantamount to pushing a noodle uphill, so to speak. If you're the manufacturer, there are always going to be new exploits, new vulnerabilities that are not going to be accounted for. And so you start to scratch your head and wonder if there isn't a better way to deal with the problem. I would also say that the manufacturers face a slippery slope with regard to assuming any sort of liability on this front, as these devices are not on their networks and they are not managed by them. So there's a whole host of considerations here that basically say, hey, look, best efforts here for sure, closer collaboration for purposes, for example, of identifying vulnerabilities that really matter, that you need to deal with. I think that's all going to happen. with the idea that there's going to be a magic wand that gets waved over time based on the device manufacturers, quote, taking care of it, I don't see it happening.
Very good, Carter.
Yeah, I mean, look, this is my passion, this is my life, and we could probably, have an entire hour just to talk about this particular subject, Anthony. But Tom and Matt really hit the nail on the head with some of the issues that make this such a challenge. It's it's a quagmire, really, because you talk about the unmanaged devices. There's a massive amount of those devices, and the variance between those devices also make it difficult because you have to apply different controls around those devices. They all require connectivity. They're ubiquitous in what we call a borderless environment of care. And on top of that, once you get that visibility that Tom talked about, there are a ton of vulnerabilities that have already kind of been pent up. And as we talked about, manufacturers, they're not obligated to build security into the devices. So even if that was a requirement today, it would probably take 10 or 15 years. We'll be retired and sitting on the beach in Miami at that time. The other things I think about that make this challenging, it's not just a security issue. It's not a network issue. It's HPM, it's supply chain, it's clinical. There are so many stakeholders that need to be involved and coordinate to get after reducing risk in really an enterprise fashion. And so when you think about segmentation, you think about patching, these things are sort of never-ending commitments, and there's just so much more to do about this challenge. But if you don't have the confidence in knowing what you have, your inventory and how those devices are behaving, none of this stuff matters. The process, the governance, indexing, correlating, context, prioritizing risk, it's futile if you're not getting accurate data and then getting it into the hands of the people that can do something about it. So that's why it's such a challenge.
So that's step one, Carter, as far as you're concerned. You have to know what you have. Step one, correct?
Absolutely. Yep,
okay, so
absolutely.
what percentage of health systems out there do you think know what they have? Guesstimate.
Tom, you'll close your ears, Tom, but I think it's probably in the single digits that truly have a handle on, let's say, 99% of their connected assets around IT, medical device. That number is growing because of platforms like Medigate, no doubt. But there are a lot of integrations that are part and parcel to enriching that information, and they're just not easy. Some of them you turn on, you get some NAC integration, you get your wireless LAN integration, those things. But there are other integrations that are really important to get that visibility that we talk about. And some of the most mature and capable organizations on this planet are still not there yet. And I know, Matt and his team, they've been putting a lot towards this over the last 2 years, and we're still working towards, understanding, are these all the devices we have on the network?
Tom, single digits?
I don't know if I'm going to argue with Carter in terms of being more optimistic. I would say that for health systems that have made investments in the latest and greatest visibility tools, which, by the way, for perspective, probably means what? Somewhere in the neighborhood of 15 to 20% of the market. That's your starting universe that we can argue with. So if you go ahead and you think in terms of the 80% of the market that hasn't really gone down this path at all, that hasn't looked at visibility tools, then maybe Carter's numbers are, empirically, correct. I mean, how do you get to a bigger number if 80% of the market hasn't done anything? I would say for the 20%, if that's the number that has made a move, they're coming up the curve very, very rapidly. I just wanted to go back and just for purposes of an additional perspective on a comment that was made about patching in particular, if you just think in terms of the number of devices in a typical health system, by the number of operating systems running on those devices, the diversity, the S-bombs, you start to look at all of that, the scale of the problem reveals itself. And it is not, the path of remediation is involves many, many, many different approaches. But to the point of your question, it all starts with having visibility to assets and the kind of visibility that you can act upon, that you can correlate vulnerabilities to make progress. And so I know I've maybe circled this a little bit, but I want to reinforce a couple of things. The scale of the problem is bigger than most people that recognize it's a challenge fully recognize, fully appreciate. And if you make trade-offs as you move down this path at the beginning with regard to visibility, those trade-offs are going to hit you between the eyes as you move forward downstream, and you look to integrate with enforcement systems as an example. So getting it right from the get-go is absolutely mission critical.
So Matt, if we say 80% of health systems out there have not gotten a hold of understanding what's on their network, you're not one of them. You've moved forward. We're going to talk about that. What prompted you to move forward? What prompted you to get into that 20% as opposed to staying in that 80%?
Yes, it's a great question. And we started, of course, we've, managed cyber and security risks for a long time, but really started down a pathway in earnest about 2.5 years ago. And when we sat down and said, okay, what does our roadmap need to look like? It started with, asset visibility generally, right? You need to know what you have to be able to put in protection controls, policies, procedures, et cetera. And it became very obviously quickly to us, and I say this is another framing of the challenge is that this is an area where we had tremendous decentralization across our organization. So, unlike managed end user device endpoints, medical devices were kind of at that time managed across multiple different departments and divisions. As Carter mentioned, probably procured through different supply chain channels with different vendor relationships and contracts and those sorts of things. So you start to look at it and you say, okay, where's our biggest risk from a entry point or from a lack of visibility perspective? Medical devices popped up on that list quickly. And we certainly been doing some past work with Carter and some of his team, and they also raised this issue to us as something that needed to be front and center. So we put our roadmap, when we put our roadmap together, this piece, starting with visibility and then getting more sophisticated over time, was front and center to it. I would add one other thing, and I thought Tom did a great job with his comments around the complexity here, but I also would say that it's also not lost on us that many of these devices are directly connected to our patients. And so that in itself creates challenges when you don't quite know what it is. You don't want to put an enforcement tool in place, turn the device off, or patch the device and cause disruption because there's no separation in a lot of cases between these devices and the child in our NICU, right, or otherwise. So that's also really important. But this became front and center because we didn't know what it was, and so we were certainly. That was our step one, is to figure out what we had so we could start putting our arms around it.
Because that's really the CISO's job more and more in terms of the discussion about the CISO's job is the chief risk officer to define risk. And this certainly is one area that probably stood out. Did the CISO bring this to you? Did your CISO say, hey, we've got a huge black hole here of risk?
So when I started as CIO here at Children's a couple of years ago, we didn't have a CISO in place at the time, right? So I was working with partners such as Carter and others to help supplement that. I'm blessed to have a fantastic CISO now, and he is a key partner. He and his team are a key partner to our risk organization, to your point, in managing cyber risk. And we also, in addition to this roadmap, put in, a much more robust governance process where we're sharing data, metrics, outcomes, approaches to what we're doing. As one of our key principles when we started to build out this program together was that we needed to provide transparency to the organization about what was actually going on and what risks related to that, and not have IT security be kind of insular to the IT team, right? And that had been the case in our organization previously. So Nate Lesser's our CISO. He does, and his team do work directly in this work every day, and really are driving this forward to levels beyond what our original roadmap set out to do, but driving in a very positive direction and explaining it, putting in context for our clinical care delivery teams and our management team, and even at a board level, the risk. And look forward to sharing a little bit about some of that work and how we do that from a metrics perspective as well.
All right, very good. Let's jump to our next question. Carter, we're going to start with you. What are some of the most important IoHT security technologies and service offerings around threat detection and response that health systems should be taking advantage of?
Well, already we've talked about the obvious, passive scanning solutions like Medigate, are essential to building capability and maturity into the programs that Matt's talking about, and getting that support. And Matt, I know you'll talk about, the board level support for this program, and building in the overall maturity of the children's, national risk, response is essential. But that platform that creates, the accurate inventory on these connected assets and all of their attributes that come with it, also need to be integrated, to contextualize the risk. And that's what Matt was talking about before. So, how do you understand how to prioritize a specific vulnerability on a device, a fleet of devices, or your entire ecosystem of devices? If you were, just chasing every vulnerability, you'd never get to it. And so you have to figure out how you contextualize it and say, all right, this is the biggest risk to our patients. This is the biggest risk to our organization, the uptime of our services, our balance sheet, our reputation, et cetera. And you kind of factor all of that in. And then you start to integrate that with systems like CMMS and CMDB that are really key platforms to integrate as you build maturity, so that the information coming from a platform like Medigate gets into the hands of individuals that actually go out there and touch the devices, or apply those patches, apply those treatment plans to the devices. And then I think about NAC, network access controls, Active Directory. These are other key integrations that enrich the accuracy of the data around those devices in your environment of care.
Tom?
If I looked at Medigate's business drivers, most prominent business drivers right now, maybe that's a good way to approach an answer. Beyond recognition now that the better the visibility, the better everything else just seems to work. I think advances in how the underlying data are being orchestrated to other systems is a major advance. I think one such tremendous beneficiary there are NAC products. The idea of being able to finally deliver full visibility at the device level to network access control, to be able to generate security policy, simulate the impact of policies before deployment. That whole ecosystem has completely transformed. It's transformed in terms of vulnerability management. Now, again, identity-based vulnerability management, identity-based scanning is a reality. These are not, oh, by the way, that's a nice incremental improvement. It's the difference between these systems that health systems have been invested in, not really performing in the unmanaged world, and now all of a sudden being able to perform there. So I think that's a major advance. I would end by saying that I think the fact that vendors like Medigate have recognized that they see utilization of these devices and are figuring out ways to normalize that information, validate, normalize, and make it useful is highly significant, because there's an ROI associated with that data, and it helps to fund these projects more aggressively across security. So there's a nice relationship there that is driving more cross-functional participation. It's good for the organization. I think it's good for everybody, because there's a business case now that I think supports this.
Matt, anything you want to add there?
I think that really when we think about that secondary piece that Tom, that second order effect, if you will, I think we're just scratching the surface on the utilization piece and our ability to maximize the devices and the investment piece. And that's, for our organization at least, that's not what we set out to do as part of this. And we haven't realized those benefits yet because of, the numerous things we focus on a regular basis. But I think that's actually a great opportunity. And certainly there's been past efforts to, utilize tracking systems and RTLS to know where things are at. But the fact that now there's better aggregation and better capabilities around actual utilization, not just location, I think is a good point, a good secondary effect.
All right,
I'll build on one more thing. When you talk about threat detection and response in your original question, we can look to a recent event around Log4j vulnerabilities and say, okay, now that you had better information, you could make quicker decisions on what actual assets within the organization need to be addressed first. And that's a huge step forward from when we look back a couple of years to WannaCry, where this challenge lasted for a long time. And I'm not saying Log4j is going away. It's still a potentially an active exploit. But when you have that information at your fingertips, you can make much quicker decisions. And I saw this real time, of course, it was over the holidays, essentially, occur in organizations that have that visibility, that have accurate information. They can respond to threats much quicker as a result. And that's huge when you look at success factors in key performance indicators that I know we'll talk about in programs like this.
All right, very good. Next question. Matt, we're going to start with you. Describe how and why inertia can keep healthcare organizations from moving forward with these technologies. Why is it hard to get going? I mean, it's always hard to do something new and different and big, but specifically with these technologies, what can hold an organization back?
Yeah, I think we've been, in some ways, we've been able to overcome some of the resistance just because of what's happening in the environment, right? Thinking back, several years ago when we were just starting to put out our roadmap, we were really defining the potential scenarios and the potential risks to our stakeholders. And then shortly thereafter, defining some of the investments we needed to make in technology and people and resource and process improvement, in absence really of what we've all now seen. Our lived experience is healthcare becoming, kind of the center of focus for a lot of bad actors. So in some regard, there's no lack of awareness, right? As we sit here today, we've seen such a number of incidents and issues with healthcare, particularly around ransomware. So that's helped. But I also think there's still an ongoing, we're healthcare organizations. We don't necessarily control our reimbursement rates. We're seeing, certainly seeing labor expenses and supply related expenses grow at a rate that outpaces our reimbursement. So to really get to your question, we have to continue to show through data, right, through metrics, where we need to get from a security risk posture perspective across a variety of really kind of complex technical areas and be able to articulate that continuously to key stakeholders in a way that helps put a fine point on what the risks are, what we want to go do to mitigate them, and then what level of investment's required to do that. But then also talk about decisions and trade-offs in that regard as well, because there's so many, cost and financial pressures facing healthcare organizations today.
And what might be a way you would articulate that, Matt? I mean, you would show data that would essentially communicate the level of risk, and then you would talk about that could mean potentially by perhaps referring to other breaches that we've seen and potential hundreds, tens of millions of dollars being out. I think it was 100 million for scripts. I mean, so that helps in terms of data, right?
Yeah, we have certainly taken those data points and applied them in context to our business, to our revenue, to our organization, and what it would mean in absence of a lot of investments to be essentially, back on paper and using non-electronic systems for a 30-day period and having to kind of recreate records and revenue. So certainly that's one aspect of it. The other aspect, which I think, certainly I think is really, really important here, is putting it in context of how we're managing risk. So one of the things that my CISO and his leadership team have done a fantastic job at is creating what we call the cyber risk index for our organization. And it really, in 10 or 11 key categories, describes key metrics that are digestible and understandable by our executive leadership team, and then tracking progress against those key metrics, on a month-over-month basis. That's been a game changer for us, because we actually worked at this for well over a year and a half to try and come up with the right metrics and tell the right story. It really, for us organizationally, is put in the context of what we've done for decades in our safety program. So healthcare organizations focused on safety and quality metrics have long, measured CAUTI rates and other key infection rates and those sorts of things. And almost as, never events, if you will, like things that can't happen. Now in cyber, it's, there's going to be, we're not going to get to a place where there's no cyber risk, but we're absolutely in a place where we can show a trend line of reduction of opportunity for vulnerabilities and other things. So putting that dashboard out, publishing it, and being transparent about it really has been really important for us to keep momentum through our program.
Very good, Tom.
Yeah, I'm really happy that Matt went down the path that he did, because I think as a practical matter, he's spot on the context of his remarks and the fact that they have actually created this index. Because where I would have gone is to have said, what's important is to figure out, work with a services partner that can deliver you early stage wins, that you can document and report, and bring stakeholders who are at an arm's length into the fold by showing them existing vulnerabilities and how they're being addressed now rapidly, that you have visibility to them and how meaningful this capability is. As heretofore, you've been operating in a relative blind. You start to make that information available to executives in different departments who are feeling the responsibility to infuse security into their staff workflows. It's understood as an organizational pursuit now, and it all works together. But as a practical matter, boy, I'll tell you what, budgets are tight, people are reluctantly moving forward, it's a tough putt, and all of a sudden, some wins are identified, they're reported with enthusiasm, they're understood, and momentum, the inertia is broken, momentum is created, and people start to see the business value associated with eliminating a lot of these outdated workflows based on, frankly, historical lag in investment on the operations side of healthcare, for decades now. So it's a relative green field. There's a lot of low-hanging fruit that if you work with folks that know where they are and can pick them and report on the value, you can get past this inertia very, very quickly.
Carter?
Yeah, and look, Matt said it when talking about that cyber risk index, providing, Children's is very fortunate to have a board that it has a vision and a commitment to reducing risk around cyber. But when you provide objective KPIs and measures, and you show that the investment that's been committed to by senior leadership is actually moving the needle, that is really important, to Tom's point. And I think of, other organizations and where I saw resistance, yes, it's complex. And so some organizations, it comes down to just a pure resource issue. Gosh, we know what we need to do. We read out there what's going on, but we just don't have the talent. We don't have the resources to do that. And also, and Matt and Nate have done a great job of this, of helping senior leadership at Children's National understand that this is not just a project. It doesn't have a finite end per se. This is a program. It takes specialized resources, but it's an ongoing thing. That is a really important distinction from other, IT implementation or integration projects maybe. And then the last thing I'll say to that, that I've seen resistance on, we haven't talked a lot about the importance in this type of program of an HTM or clinical engineering department. But some of those organizations that maybe are thinking in the past don't necessarily want to be exposed. And what I mean by that is those leaders in HTM or clinical engineering or biomed are accountable for the safety and just the overall inventory and how those devices actually work. And I would say some are fearful that if you put an actual device on the network that says, okay, here's where they're all at and here's how they're behaving, some of those individuals say, gosh, I might be exposed, and be accountable for that risk. And so that I've seen real resistance there. And so we need to kind of work to overcome that feeling and help those individuals understand this is better for the organization, from an enterprise risk perspective.
Yeah, there's only one thing that I would add that I think is notable here, and Carter touched on it. When we speak in terms of inertia, there's a people problem for sure, and it's often overlooked. A lot of health systems that I have experience with understand where they need to invest, how they need to invest. They know what they need to do, but they don't have the people to pull it off. And so they're looking for service providers that can fill those gaps. Necessity being the mother of invention here. We're seeing all sorts of new hybrid type tech-enabled service models emerging to address this problem, but it's a big component of the inertia.
So Tom, they're saying it's a great tool you're offering me, but I just don't have the bandwidth capacity or people to run this tool in terms of operating it and then taking action when it's giving me alerts that something's wrong. So if you offer me a tool and a service, maybe I'm interested. Is that what you're saying?
That's exactly what I'm saying.
No, Matt, does that make sense? I mean, maybe not for your organization, but you can see other organizations just not having the bandwidth to execute on some of the stuff.
Well, certainly, and back to some of the key tenets and principles when we put together our cyber program, one was to balance investment in tools and technologies with people. Because our historical approach had been to buy tools, but not to maximize their utility because we didn't have enough resources to support, maintain, and do exactly what you're saying, Anthony, which is using the monitoring and measurement. Certainly, and it's certainly that's not not an infinite resource. We're not going to get people. So I think as we look forward, just as organizations have traditionally done, for kind of SOC type monitoring, I think that will continue and continue to create opportunities for organizations to really partner with managed services providers to go drive some of these topics forward, and maybe in a more specialized way, like medical devices.
All right, very good. Tom, let's go to you on this one. Discuss how early stage progress reporting and integration sequencing can move IoHT security projects forward, and address and explain the concepts of mean time to remediation and asset utilization reporting. So a little primer there for our folks.
Yeah, well, I appreciate the question, and I'm going to, and I'm not going to dodge it, but I'm going to throw it at Carter. I think that I have just commented on the importance of creating a scenario where you can have some early stage wins, know that you're going to be able to deliver those wins, document and report on them in ways that is going to drive engagement from leadership, possibly loose some purse strings on budgets, and keep that progress, front and center, high profile. The reason why I'm punning to Carter is because mean time to remediation is a concept that essentially he has associated with this, and it's very much how First Health operates with clients. They very much understand the practical value of doing precisely what is suggested here. So how about if I let you run with this, Carter?
Yeah, I'll take it, Tom. And yeah, absolutely. When you think of mean time to remediate, or even mitigate, and there are some key differences in those two terms, but it's the time that it takes between when you identify a vulnerability and when you actually do something about it to fix it or lessen it. And so when you think about Matt's comments and what his CISO Nate is doing around cyber risk index, that is an absolute key performance indicator to be able to say objectively, it used to take us 20 days between when we found out there was a problem with a specific asset and when we actually remediated it or mitigated it. And so that is a performance indicator. Now, there's some factors that the healthcare organization may not be able to influence. If you're waiting on a patch from Philips or Becton Dickinson or some of these other medical device manufacturers, you're at the mercy of that organization. But it is an absolute key metric, and the better information that you have in the right hands, you should be able to reduce that metric over time.
That's good. Tommy did a good job with that. All right, very good. Matt, let's go to you on this one. Why is it important to present performance metrics in a risk context, and how is this done? You mentioned the index you're doing. Is that pretty much your method?
Yeah, the index really is our method. And just to validate what Carter's saying, we haven't used mean time to remediate. We just call it average dwell time, which is pretty much the same thing, right? How long are these vulnerabilities in our environment? And one of the things that that our team routinely points out to me is that actually looks worse before it gets better, right? So as we discover more, as we get a better understanding of both the things in our environment, but also their characteristics, we're reminded how much we have to go do to bring that average or that mean time to remediation down. So, but it's really important, to just to put a highlight on our prior conversation. It's really important to do this, to put the metrics in a risk-based context, because it really, in absence of the risk, it's just looks like expenditure, and there's like, the question that might come up is, how much is enough, right? And so how much is enough is answered by how much risk are we willing to accept organizationally for a particular topic or segment of our care delivery model. And really that's what the index has allowed us to do, is to say, not only track that progress, but our team worked with, our cyber governance committee, our cyber security oversight group, and worked with them to jointly define the metrics, right? How many devices should we have in our environment with a a dwell time over a certain limit. So rather than just us setting the context, of course, we did it as advisors and we gave them the kind of what the concerns might be for each of these items. But that joint exercise actually created some level of shared accountability and responsibility across lots of important key stakeholders in our organization, and a better understanding, a better grounding of, what does it mean if we choose not to make certain investments or not to put in certain policies or procedures or controls. And that's really, really important for us.
Carter, when you're dealing with clients, is this kind of how the discussion goes about risk in terms of investment versus risk? So you want that risk number to go down, the investment has to go up.
Yep. Matt's spot on, right? Aligning those metrics with the business goals of the organization. So, what risk do we accept? What risk do we, move over to our insurance? What risk do we actually get after? And it becomes an enterprise risk discussion. So it has to fit in with all the other areas in context of risk, and what those metrics allow organizations like Children's National to do then, if it's good data, is make decisions on how you allocate resources. So if you don't have that information, how do you know how many people to put on the people, process, technology challenge? And so that's a big element of these programs, and understanding the metrics and how they align with the organization to say, this is how much we're willing to invest. And if you have those objective numbers, it really helps with the conversation.
Tom, I want to get an audience question in front of you. Let me abbreviate here a little bit. The problem with understanding the real vulnerability state of devices is that quote unquote passive scanning only provides an initial assessment of vulnerabilities. It is still laborious to have a true view of vulnerabilities from a single tool. You see that question there? I don't know if you see it.
No, but it's in the Q&A here.
Yeah.
Well, I heard
it.
I heard it. So my comment is, if your notion of visibility is limited to what you believe can be parsed from a traffic flow, regardless of how skilled the deep packet inspection is, I'm going to agree with you, and then say, but that underscores the need for doing business with vendors that are dedicated to the space and have the bandwidth to then do the offline R&D required to enrich that baseline of information with things like the operating requirements of the device, its workflow, its authorized connections, digging deeper on a continuous basis to understand at a level of detail that allows you to threat process more effectively or optimally. Visibility directly ties to the effectiveness of threat processing, obviously, but only to the extent that you have an enlightened idea of what visibility can encompass. So, hey, if you don't know the authorized behavior of a device, then how can you monitor for unauthorized behavior effectively? And so I think my answer to your question is, don't limit your understanding of visibility in terms of DPI. Think in terms of vendors that are deeply invested in enriching that information, that data foundation on a continuous basis.
All right, very good. Oh, go ahead, Carter.
Real quick, because I see this and I understand where the questioner is coming from, and yeah, I'll be the first to say it. There's no one magic bullet here that solves the problem. That's why there are businesses out there that are trying to address this every day. But I'll say you can't do anything if you don't start with information that comes from a platform like a Medigate. And that I talked about it earlier. CMMS is an extremely important integration here, because then you start to correlate that information with the device history, its maintenance history. Those types of things are really important then to understand what you need to do to reduce that risk. But if you don't have the attributes, if you don't know where those devices are, and that information that'll come from Medigate, you can't get to phase 2 or layer 2 of correlating that information. And so it is a very, very important piece of the puzzle to be able to passively scan these devices and know where they are, the attributes associated with them, and behaviors associated with them.
All right, very good. We have a question here that we've prepared, and it's also a similar one has come in. So I think I'm gonna put this in front of you, Matt. Discuss how stakeholders involved in a mature program can collaborate in pursuit of risk reduction and life cycle efficiency. The question from the audience is, since deploying Medigate, has your IT department become more cohesive, as in networking, security, biomed, and facilities? Visibility of all connected devices is key when it comes to identifying risk and exercising prevention for IT as a whole. So I think those are related. You tell me.
Yeah, I think they're related too, and I think it's a great point, right? So and every time I listen to someone like Tom or Carter talk about the technology itself, I even learn or expand my thinking about how we could use it. But in addition to that, this is fundamentally, as the questioner is pointing out, is a governance issue as well, right? So how are you going to go use that valuable data and go execute strategies that are going to improve the situation? And I will say that the answer to the question of has it brought these departments together and more closely aligned is yes. I will also quickly say it's a work in progress, right? And that alignment continues. In addition to that, we've done that, a lot of that, and we've done that through, the kind of a Gen 1 of a programmatic approach, and gotten a lot of invaluable insights from Carter and his team and others on how to build a program around this, because it does involve so many stakeholders. And I think we can continue to mature that governance. The other step that we've more recently taken, which I think, and I'm hearing a lot of organizations, is we're investing actually in a human in a role of medical device security under our CISO, under Nate, to go kind of lead this work, because it's so involved and complicated. It really does need to be somebody's day job to go do that and liaise to these very important functions. And in our organization, we're bringing in a former biomed director to do that. So it's gonna really help us, I think, as we continue to mature and think about the device security here, building off that program and foundation we've created to kind of make this a continuous, ongoing, and kind of maturing effort.
All right, listen, we are almost out of time. We're going to do a little lightning round of final thoughts here. So I'm going to go to everyone in maybe 30 seconds. Your final parting piece of wisdom or advice for our healthcare IT executive listeners. Think CIO, think CISO. Help them out. Carter, what do you got?
Wow. Okay. I'll try to make this quick, because I've heard it and I still hear it, right? This idea that nobody has been harmed or died from ransomware or an infusion pump being hacked. I don't know why we're doing this. I still hear that. In fact, 2 weeks ago, I heard it, and it makes my blood boil. I'm not a FUD guy. Matt knows this, Tom knows this, but I say that's total BS. And it's putting your organization in a really dangerous position if you take that position. There is objective evidence that cyber attacks are really a catalyst for degraded functionality, hospital strain, and hospitals are strained already, but delays in treatments or diversion of ambulances, they're having a marked negative impact on health outcomes and even increased mortality. And so, look, this is my passion. I see a lot of scary stuff out there. There's some negligence, shortfalls in duty of care, including underlying staffing shortages that make this all the more difficult. But this is a time to be more vigilant. And believe me, there are bad actors out there that want to take advantage of the stress in the health system right now. And I believe that an attack on any healthcare entity is a threat to our whole ecosystem of critical infrastructure healthcare. And so I would say, get after this challenge.
Very good, Matt.
Well, I appreciate Carter's passion on this topic, because it is, we talk about measuring the effectiveness of our cyber program in the way we've measured quality and safety. And I think he appropriately points out that the two can be indistinguishable at some level. Like there's not a gap between the appropriate functioning of these devices and their availability and how the care we're delivering. So it's absolutely spot on. I would just leave this group with really, and we spent a fair amount of time on it, but it's robust world-class technology. There's no doubt about it. These systems are really important to get visibility and to continue that visibility and be able to do meaningful work in identifying threats and vulnerabilities and managing them. But it's the technology plus the programmatic approach that brings all the key stakeholders together to go react and respond and reduce the dwell time or mediate faster. And then it's the importance of showing that data to our stakeholders to continue the pathway and the trajectory and building a robust program. Those are the key elements in my view, and I appreciate the opportunity to speak with you all today on this.
Thank you, Matt. Tom, last word.
Yeah, well, I would say as a starting point, make sure you have cross-functional leadership engaged. This is an organizational pursuit. Do not underestimate the ROI associated with an integrated approach to asset management and cybersecurity. The vendors are attacking a green field. There is a payoff here that is sustainable. And finally, as you're evaluating solutions, check references for operationalized examples of those that you see as high value. There is a big difference between a vendor saying we exchange data via an API and a meaningful, operationalized, value engineered integration that delivers use cases that are difference makers. So take the step. I don't think you'll find problems these days finding a peer who is more than happy to give you a guided tour of what they've been able to accomplish.
All right, very good. Thank you. Regarding continuing education, you can use the final slide in this deck. You'll get an email when the on-demand recording of this event is ready for viewing. If you want to sponsor an event with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming webinars. With that, I want to thank our panel, Matt MacVay, Carter Groome, and Tom Finn. I want to thank our sponsors, Medigate by Clarity and First Health Advisory, and I want to thank you, our attendees. And with that, everybody have a wonderful day. Thank you.
Thank you.
Thank you.